Yeah, going live.
Okay, so I'm going to start now. So good afternoon, everyone who all are tuned to our broadcast today, and thank you for joining us for this very exciting first of a kind thing at TIFR. I am Jyotishman Das Gupta, the Wednesday Colloquium Coordinator, and along with me I have Dr. Satyanarayana, the coordinator of the ACET Forum. And we are both proud to host the first of its kind Wednesday discussion room as part of our traditional NSF Wednesday Colloquium series. So now the Wednesday Colloquium series is the oldest form of science dissemination in the Institute, where all members of the science faculty usually get together on a Wednesday afternoon to listen to lively exposition of contemporary science problems from experts in the field. This could be in physics, chemistry, or biology, or even engineering disciplines. I'm actually, while doing this event, I'm actually honored to be sitting on the shoulders of many amazing colloquium coordinators who have passed on this particular responsibility to me to keep the quality of science at the highest level by choosing incredible speakers. We, in fact, have a great list today as well. But I would like to just sort of ask older, colloquium coordinators to raise their hand if they are in. I know the previous colloquium coordinator, Bhashwati, Sushil, Roop, who have all passed on this information. GRK, who has raised his hand. Sudipta was one time a colloquium coordinator. I would like to thank all of you for carrying this tradition for this long and essentially ensuring that this particular activity, this particular event is, held its, heritage for this long since Bhaba's time. So thank you all. So you're all with me on this, that as we unveil this particular forum, known as the Wednesday Discussion Room, whose primary focus will be to go beyond the colloquia we typically hear and from the NSF colloquium, and pull the speakers who have given these colloquia in the last 3 months, such that there is a common thread that connects these speakers' work together. So with this idea, we would like to launch this particular discussion room, specially choosing a topic which has made this colloquium really online, the COVID pandemic. And of course, to do this, it is important that a moderator is there who can moderate this entire session in a structured manner, and the audience, that is you, who would participate in such a structured and organized discussion group. So before I start the proceedings, I would like Dr. Satyanarayana, the Asset Forum coordinator, who always is standing next to me, supporting all the events that I do, to please speak a few words about the Asset Colloquium as well, since this is a joint NSF Asset event.
Yeah, thanks, Jedi. This is always a great pleasure to team up with the Wednesday Colloquium and probably adding some value in these particular troublesome days to both technologically and also otherwise, and to bring the audience, the participants, in a larger way and make these discussions more lively, maybe bringing a new dimension of technology and engineering to this, as you said very rightly, the very traditional, the science, natural sciences forum. So today again, we joined together, and I think we should more look forward to very important and at the same time very interesting discussions by this panel of experts who have been doing wonderful work while all others were probably stuck to home, but I think they have done in their own field of specialty lot of work that has actually made a big difference to our neighborhood and to our city and even to our country. So we are all very excited to listen to their experiences, and I think, so let us go. We are all looking forward to a wonderful session.
Thank you, Satya. And Satya, as Satya mentioned, these are the three colloquium talks that were organized by NSF and Asset Forum together in the last 1 month or so. You can clearly see the colloquium speakers back here in the panel, and also, giving us more information beyond what was discussed individually in those colloquia. Before I move on to start this proceedings for the day, I would like to really have a 1 minute silence for from all of you. I'll request a 1 minute silence in the memory of Mr. Nitin Pallav, who actually passed on due to a COVID complication. Passed away in June of 2020 due to a COVID related complication. We sincerely mourn the loss to his family as well as to the TIFR collective. So I'll just keep a 1 minute silence. Thank you so much. Now I'm back to start this particular session. Moderator is Professor Sudipta Maiti, one of the very well-known biophysicists that we are lucky to have in our community, and a spectroscopist who has been known for his work in amyloid proteins for a long time. And now, because of the pandemic, has shifted his research attention to the COVID problem. So Sudipta, the floor is all yours.
Thank you, Jyotishman, and thank you, Satya, and welcome to this special Wednesday colloquium, which is a discussion room. And we are in the middle of a pandemic. It has been 8 months or 7 months plus, and we still don't see any end of it. It's nothing like our generation has ever seen before. And back in March, if you remember, when you knew very little about the pandemic, the doctors got busy, put their lives on the line, started saving lives. But the onus has fallen on the scientific community to find out more about this enemy that we knew so little about. The procedures to tackle it, to contain it, and finally for finding a lasting solution that will pull all of us out of this situation. So that actually galvanized the scientific community all over the world. And people started collaborating in a way that's unprecedented during my scientific life. You ask a sample from anybody in the world, they're ready to give. That's really the kind of collaboration we have seen. And yes, now in October, we do believe that science finally will have an answer. Sometime, hopefully, in the next 6 months or so, we'll have a vaccine that will finally start making a difference. But that doesn't mean that everybody will have the vaccine anytime soon. It will be many years, as even the vaccine makers have said, that everybody will be safe with the vaccine. So we have to open up, and we have indeed opened up before that. And we have to think about ways that we can keep ourselves safe and what to do next. In this, the world community of scientists, TIFR scientists are also part. We are not a clinical research institute, but we realize as all TIFR scientists do, that the payment to our conscience, payment for our conscience, and the payment to our salary accounts do not come from saving our own backs. And that everybody realized, and everybody from biologists, chemists, condensed matter physicists, theoreticians, computer scientists jumped in to see how they could help. Nobody said, is this my field? Can I make a big difference? Why is it that I am being called, or why is it that I should be expected to do anything? That's been unprecedented. And there's been collaboration through the TIFR system. That's what we'll talk about. We had at one point, for many months, weekly meetings held by V. Chandrasekhar, by Satyajit Mayer, amongst all the, taking all the campuses, something that all of you may not know about, and including our own Sandip Trivedi holding weekly meetings, taking stock of situations, asking what he can do to make a difference. So I'm proud of the TIFR response, and the response is still going on. You have heard some of that in our June 1 meeting that we had, commemorating our 75th, and you have heard some of that from our colloquium speakers over the last few colloquia who are present today as panelists. I would share my screen and tell you what I would like to do today. It's more of a discussion room, but I'll start with telling you a little bit about things that you may not have heard about. So I'll share my screen. I hope everybody can see it. Okay. So there's the plan for today. I'll first tell you about some less well-known efforts for developing diagnostics, which we hope will have far-reaching consequences, and you will be, as TIFRites, proud of these efforts. Okay, but things that you haven't heard of probably before. Then the real discussion room will start. We'll have three main areas that we'll concentrate on. The possible trajectory of the pandemic, about testing and tracing, and about work-based measures that you can adopt. There is going to be using TIFR as a laboratory kind of, but as I said right in the beginning, we know that our job is not just to save our own backs, it's to fight for the country, if necessary, offering our own backs. So this is a way to tell ourselves and others that this is how TIFR is thinking about opening up safely and keeping everybody safe as possible. So this is the discussion room, and we'll have concluding remarks. But let me first start with the some of the less well-known efforts, because these have not been covered before. So I have chosen three things which all have to do with diagnostics. You will hear about some diagnostics today, but you already know. You already know RT-PCR, the time-consuming, money-consuming effort that has to be gone through. That is the gold standard for COVID detection. If it took 2 minutes and 2 rupees, all of us would have it every day and quickly contain the disease by now. But that's unfortunately not the case. However, it could be, if not 2 rupees and 2 minutes, maybe 200 rupees and 20 minutes. That's the effort has been, just to take RT-PCR out of the equation. I'll talk about three, quickly go through.
Sudipta, can you just go full screen?
Could you use full slide? Full slide. Thanks.
Okay. Sorry about that. The first effort I have picked up is from TIFR Hyderabad, and you can see the names is Manish Jaiswal and his co-workers. And here's something called a loop-based amplification. All of you know, and I think Ullas will cover later. It's an RNA. It's an RNA virus. It's a single copy of RNA is a single virus. You have to amplify it so that your instruments can detect it. And there is a new amplification strategy that had been developed some years before, which has been put in for solving this problem by Manish. And as you'll see in my, in this slide, this is actual samples from patients. And you see the color change. This is a naked eye detection done together with the ESIC hospital, ESIC hospital in Hyderabad by Manish and his collaborators. You can see that depending on the viral load, the color changes. And this color change, it's normally red to start with, it's negative, and the color change is very obvious with your eyes, and it happens within 30 minutes, as is shown here. And he has very good positive, very low false positives and very low false negatives. Sensitivity is almost as good as RT-PCR, and we are already talking about going the commercial route, not for the commerce of it, but for disseminating this technology as far as possible. There's a second effort from NCBS from Aarti Ramesh, one of our younger colleagues, together with Akash Guliani, who is now in the University of Hyderabad. This again bypasses the RT-PCR, and it uses something called an RNA aptamer. Okay, so the RNA aptamer is a recognition element that can recognize the viral RNA. Again, the RNA has to be extracted from the virus, but no RT-PCR needed. And she has shown that something like a typical strip-based diagnosis kit, something that some of us are familiar with as a pregnancy kit kind of thing, that can be used with this. And these are the results that she has shown. This is COVID negative, and you see somewhat yellow. This is COVID positive, but low viral load, it's pink, and this is COVID really positive, high viral load. This becomes red, and the color change tells you that you have. There's another thing that also there are talks on with a company which hopefully will commercialize it soon. There is some effort that some of us have been busy with for the last few months. Ravi Venkatramani, Ankana Datta, ASR Koti, Ullas, Kolthur, Kollaneshwar, of course, from TIFR Hyderabad. There is an effort between Kulab and Hyderabad and my lab, and especially thanks to our students, Anirban, Amitava, Ankur, Anuradha, Anup. They all seem to have names starting with A, except for Sandra and Vicky. And we haven't quite reached the point where you could detect it and commercialize it. But this promises to be an extremely sensitive detection that doesn't even need the RNA. It's a full virus detection. So it will be quite special if we succeed. So I wanted to cover some of that before I got you to the discussion room. So let's enter the discussion room now. I'll go back up and start the discussion room. And I will do it in a way that one of our panelists or two of our panelists will speak about each for some pre-designated time, and then we'll move over to the next one. If you have questions, please raise it. And we will take the short questions during the colloquium. We'll wait for the end of the colloquium for the long questions. But all of my colleagues have promised they will be here as long as the last question, as it takes to answer the last question. So
I would request all panelists to switch on their video, please. Ullas as well.
Okay. So the first one is the possible. So this is something. This is all in all of our minds. The possible trajectory of the pandemic. Where are we, and where are we going from here? That's to do with all of us, who most of us live in the Mumbai region. Okay. More specifically, in TIFR, in our workplace, we are treating it as an example of a workplace. And finally, in TIFR colony and perhaps a couple of other colonies such as Mandala that many of us live in, as an example of a typical housing complex. So at this point, I hand it over to Professor Sandeep Juneja, who has thought about some of these. Sandip, you're on.
Yeah. So I can share my screen.
Please do. I will unshare.
All right. Okay, so this is the situation right now. So
okay, we have not seen your slides yet. Sudipta has to unshare it.
Yeah, I am trying to unshare. Somehow the unshare is not very good. Just bear with me for a minute, and let me, if necessary, I'll just quit and.
Should I stop share and start again? Let me do that.
Let me quit. I'll go back in because you need to go back in. There's some problem with my computer, which is just not stopping the share.
Sudipta, do not quit. If you quit, you may not be able to join.
Okay, I unshared it.
Oh, great. So if Jyotishman can do it, that's okay. Yeah.
Let me share. Okay, so this is, let's see. Can you see my screen now?
Yes.
Okay, so this is where we are. You know, it's a grim situation. So worldwide, we have 35.5 million cases. India, 6.7 million cases. So India is the second highest cases worldwide, not very far from being the first highest. Maharashtra has 1.45 million cases. So Maharashtra is leading all the states in India in the cases. And Mumbai is pretty grim at 215,000 cases so far. Fatalities, you can see worldwide it's 1.04 million. India has 104,000 fatalities right now. Again, Maharashtra leading the pack in India with 38,000 fatalities. Mumbai has 9,155 fatalities, although true value is likely to be closer to between 12,000 and 15,000. That's because there have been there was a report that there are excess deaths in July. There are about 14,000 excess deaths compared to last year in July. About 6,500 are explained by COVID, but the remaining are not. So with that, you do some adjustments for a variety of other phenomena that happen, and you come to the number that it's between 10,000 to 15,000. So that's the number I'm going to keep in mind. Okay, but I guess the bigger picture here is that, I think Mumbai, you can still say that there is some silver lining, that there's enough people who have been infected, so one can hope for things to stabilize in the coming months. You can't say that about India. So if you see the picture on the left, the most of the population resides in this Hindi belt, and we've just begun to see infections there. I mean, it could well be that there are a lot more infections there than are reported. There's a lot of population in the south and then towards West Bengal and all. So, I mean, there's room for, it's not quite clear that things have stabilized in India. And, we'll see large number of infections, a lot of suffering for many, many, many months to come. But for Mumbai, we had this Mumbai Sero survey. So end June, one estimated that about 55% of people in the 3 slums that were tested have been infected. About 15% of population in the 3 non-slums. If you use those numbers, you expect about 4.7 million of people in Mumbai from about 13 million to have been infected by end June. About 40 days later, there was a second round, 45 days later. Now, if you saw the newspapers, the report said that the numbers actually came down. 55% became more like 45%. But that's really because the antibodies, very likely because the nucleocapsid antibodies that we are detecting for decline fast. That's just the test that we used. At that time when we used that test, this was not so clear. If one were to use other calculations and make adjustments, that's an ongoing process right now. We have other antibodies that we also are testing for. One expects above 70% prevalence in the slums currently. This is in around mid-August, and about 30% in non-slums. So about 6.5 million people infected. So that's the kind of estimate one comes up with. What's interesting about 6.5 million is that you can come at this number in 2 different ways. If you take a number that's widely going around, that for India's age profile, you expect about 0.2% chance of anybody infected resulting in a fatality. So then if you take 13,500 to be the 13,000 there also be the fatalities in Mumbai and reverse calculate, you again come to something close to 6.5 million. So it's right in the ballpark. This is the kind of number one may expect right now, people being infected in Mumbai. What's interesting is now, as I mentioned, the death data, so you can't really use the death data that's available to us because there are many missing numbers to come up with infection fatality rate. But in this Sero survey, what we also did was we asked the people who were surveyed, give us the age distribution of your household. So these are randomly picked up people telling us about their family sizes. So that gives us a fairly good idea of what the family sizes are in, what the family ages are, in profiles are in slums and in non-slums. And just from that, you see that the slums are much younger than non-slums. And you estimate that the infection fatality rate from slums is about 0.13%. That means if you're living in a slum and you get infected, there's a 0.13% that this will lead to a fatality. While in non-slum, this number doubles up to 0.25%. It's just from those numbers. I mean, there are many missing data involved, but I would expect that if anything, the real actual numbers would have a larger gap between slums and non-slums. So non-slums have older people and should have a higher infection fatality rate, even more than what is suggested by age. All right, so let me just go a little bit about, let's see if I can move my slide. Yeah. So this is a plot of the possible trajectory of the disease for Mumbai. Mumbai is what we studied. This is joint work that Piyush, Prahlad, Ramprasad and I have been doing from STCS. And we've been using this simulator that was jointly developed with ISC, so ISC TFR model. So we applied that to Mumbai. Now this curve is the fatality curve. The red bars are the actual fatalities that we saw on a daily basis. So you can see that, around mid-March, after mid-March, the fatalities started growing in Mumbai. they peaked around May 15th to beginning of June. So that's when you were seeing some peaks, about more than 80 fatalities a day. Sometimes even more than 100. This was the time when the ICUs were all full. Now, thereafter, numbers have been declining. There are these kind of difficult to explain gaps in between. We don't quite understand them. But numbers have been declining. And then you see around, between August 15 and September 1st, you start seeing another kind of rise in numbers. Some of it is because, the workplaces opened up substantially beginning of August. So that led to some more intermixing and some more infection spreading, which in a few weeks lead to fatalities. And some of these numbers are also because of, I guess, maybe the Ganpati interaction. So overall, people were coming out a lot more. Compliance was much less than before. So you see larger numbers. But currently we are seeing about 40, 45, fatalities per day in Mumbai. So this, as I said, just from the fatality data that suggests about 6.5 million odd people already have been infected. That tells you that, given that Mumbai's population is 13 million, so I'm just looking at greater Mumbai right now, 13 million, a little bit around that. That, eventually with some more, as people get more infected, the numbers will have to decline because there really aren't that many more infectious people who are infecting the susceptible people. So we do expect numbers to decline. Although having said that, currently the building residential areas, the kind that we live in, we are seeing about 25 to 30% kind of prevalence. So these are places where numbers are rising right now. So, we have to be very careful. This is the time to be very careful for us. But we are, I'm showing some of our model projections. So the orange curve and the blue curve. Orange curve takes into account this Ganpati kind of spike. The blue curve doesn't. But basically what they say is that you should expect things to look much better in December, January, thereabouts. Even if you were to open up the overall economy by November and open up schools by June, by January, you should see numbers which are much lower than now. Now, having said that, even if the numbers are lower, a large percentage of people that we, amongst us will be uninfected. So wearing masks, social distancing is here to stay. Because every now and then someone will be infected coming from outside or from somewhere, and we'll have to be careful. So, that's not going to go away. So situation will be more relaxed from government's point of view. They'll have the hospital beds available, infrastructure available to take care of people, but we'll have to be maintain social distance.
So, Sandeep, can I interrupt you and ask a question on the previous graph?
Sure, please.
What is this sudden spike around January 1st, December 15th to January 1st?
So this is if you open in November 1st, the economy. Now it takes about 3 to 4 weeks because before the numbers start, the increase in infections will happen then. After 3-4 weeks, you start seeing the number of spike in the fatalities.
So that's the assumption, the opening up.
Yeah.
Okay, thank you.
Okay, so this is the. Sure, go ahead. Let me actually come back to this if we have time, but maybe in the interest of time, let me just come to the TFR colony situation just to bring points home. So in the colony, we estimate about 300 families and about 180 students. So ballpark about 1,000 people in the colony. We've seen about 13 cases so far. And all of these are in the last 2 months. So about 1.3% people infected. I mean, you can quibble about the number. It could be 1.5%, could be a little bit less. Now you compare this to about 2.6% for Mumbai non-slums. So from 215,000 infections that we've seen in the city, one calculates how many came from non-slums and divides by the population in non-slums. And that number is around the ballpark 2.6%. So we are doing better than the residential areas overall in Mumbai, as one would expect. This number is 0.8% for slums. But that's just because the cases in slums don't get reported as much. We've not seen any serious case so far, and by a large proportion, Mumbai gets tested only when they have severe symptoms. So that's another reason our numbers are low compared to the rest of residential Mumbai. Now, in residential areas, one can compute that there are about 11 infections result in one reported case. So about 11 people have to be infected, and then one of them is serious enough or some testing is done and is caught and is reported as a positive case. In slums, this is about 30 infections per case. So for every case that you see, there are 30 more infected people in the slums. And in slums, it's very clear that people get reported as a case typically when they have severe symptoms. They go to the hospital, they get tested, and they turn out to be positive. And then a few more people after contact tracing get reported like that. In our kind of, I guess, in residential colonies, people tend to kind of with some amount of symptoms, you do get tested faster, and that's reflected in the numbers. About 40% of people who have symptoms if they're infected. So 60%, this is just a rough ballpark estimate. The 60% of people are typically asymptomatic, so 40% have symptoms. So basically what we are saying is about 1 in 4 symptomatic end up getting tested. Other 3 have mild symptoms, they just kind of live through it and then recover soon. So speculative conjecture for TFR colony is that this number, 1 in 11 should be lower in TFR simply because I think TFR is more likely to report, to get oneself tested if there are mild symptoms. And then we are doing other things like we had RAT tests done, here or people are flying, so they have to get tested. When you get tested, you're like, there's a small chance that you'll turn out to be positive. So in TFR, you expect maybe, I would guess, 5 to 10 infections may lead to 1 reported case. And what that means for us is that we've seen 13 infections, so maybe around 50 to 150 people are infected in our colony of 1,000 people so far. This is speculative. If we were to do a sero survey, that would be one way to measure this. And as I mentioned, and a message from all of this, from TFR, if you examine the cases we've had, is that mask and social distancing, by and large, are protecting us. It's a standard statement, but they seem to be working, and there's no worry there. All right, with this, I'll stop for now. Maybe Shorindu can.
Thank you very much, Sandeep. So that's those numbers should be kept in mind, even if they are very approximate, because our behaviors cannot change. Behaviors need to depend on that. Thank you. So can I request Shorindu to come in with some of his comments, because he has been also doing a lot of modeling, and especially if he does have something to say about the TIFR as a workplace and what is his cases are about that. Shorindu?
Shorindu, you're muted.
Unmute Shorindu.
Thanks. I'm starting the screen share now. And so you heard about the data, you heard about models, and it's very hard to carry them into a smaller place like TIFR because we want to, when we open up, we want to be safe, we want to be working as best as we can, but safely. And this will require behavioral changes in all of us. Okay, and human behavior is something that's difficult to model mathematically. So I could give you mathematical models, and I'm not sure how well they will perform because inputs are not known, how people will react is not known. So if you think of the problem in the following fashion, supposing TIFR were working at full go, and there was a fire in the institute building. Okay, I'm sure most of us will come out safe. But when we look back at the path that we took to come out, it will be completely unpredictable. Okay, I don't think we can give mathematical models to tell which part will get crowded, which part will not get crowded. But on the other hand, it's possible to create an office design where such things do not, such emergencies do not create traffic jams. Okay. So that's the kind of thing that we should take from modeling. What are the likelihoods? What could happen? And how do we go around, get around bottlenecks which would create problems for our work? Okay, so let me start by reiterating that when you get COVID-19, that is, if you do, it is through your network of contacts. Okay. Now, what we can do about it, what TIFR as an organization can do about it is beyond the control, beyond our own control. Okay, for any organization, it's not possible to control what's going on in the world at large. Instead, we should think about arranging our work environment so that everybody is safe and that the pandemic affects work as little as possible. Work can progress. Okay. So what do I mean by network spreads COVID-19? So look at a typical social network. So that's the thing on the left. Each of these red dots is supposed to be a person. So there's a graph of say 100 people, maybe the faculty, maybe the students, maybe some set of workers in the institute. Okay. And the lines denote uh, the social interactions that they have. Okay. So some people have more connections, some people have less connections. Okay. But it's a complex network, very unstructured. You don't know who meets whom, why they meet somebody. Okay. But it contains people like your family, your friends. If you're traveling by train, then the friends you make on the train, maybe the general store that you go to buy your milk. Okay, the people that you meet there, maybe the bhajiwala and the people that you meet at the bhajiwala, maybe the dhobi and the people that dhobi connects to. Okay, so all those go into building your social network. And as I said before, it's totally unstructured. There's very little we can do as an organization to restructure this. Okay, it's an individual's own choices. What we could do, however, is to look at the work network. Okay, and the work network is usually much more structured because they're close colleagues with whom we work often. They're work teams, lab workers, okay, people you work together with in the lab. Okay, maybe there's your secretarial staff. Maybe if you commute to work, then the carpool that you take. These are your work network. Okay. And typically, this is much more dispersed. There are fewer connections. Okay, they're independent networks. So here I had about 100 people in this network, and you can see that that's pretty unstructured. There's 100 people here, and usually they'll break up into groups of small people. For example, there's lots of single person networks here because there are lots of people in our institute who might be working more or less alone. Okay, maybe they meet other people now and then, but most of their work is done alone. Okay, and we must think about tracing such graphs and seeing how we can utilize that. So let me summarize this part of the overall structure by saying that typically a lab will have a few people coming in. Each work group will have a few people coming in. I think there are 10 in this case. Okay. Each of the people who comes in, however, has his own social network, which is different from this work network. Okay. This social network can be very complicated, and we must learn how to make sure that if a person carries an infection into work from his or her social network, how can we ensure that it does not spread through the work environment into other parts of the social network? Okay. So how do we do that? We would like to do that by looking at the most important passages through this network, okay, through the work network. And I think one of the most important concepts we have to keep in mind is that COVID has something called super spreading. Okay, it works in this way. If you take all COVID infected people, then about 10% of the people give rise to about 80% of new infections. There 20% of the people give rise to only about 20% of the new infections. So each person each in this 20% passes the infection on to one other person. Each of the super spreading events that involve this 10%, each person passes it on the average to about 8 people. Okay. And that means that there's a 70% of infected people don't pass on the infection. Okay. So this pink is the super spreading events. So if you can control the size of gatherings in the workplace, you may actually be able to remove 70 to 75% of all infections within the workspace. Okay. For example, can you do this? If you say that in the workspace, I will somehow try to keep the maximum group size working together at one time to 4, okay, then that means that one infection can spread only to at most 3 more people. So you have reduced this super spreading by 50%. Okay. So you must then think about how to structure your work habits, your work environment, so that at one time, no more than 4 people come together. Okay. We could do things like move meetings like this online, which we have already done. We should continue to do that perhaps. Okay. If we have large labs, maybe a group meeting could be taken outdoors where the chances of infection are smaller. Okay. We could stagger times, other places where people come together, for example, canteen. Okay, we could stagger usage times for the canteen so that very large number of people do not come to the canteen at the same time. Okay, if there are large shared workspaces, for example, in our department, many students share workplace. And what we are trying to do is to stagger timings so that fewer people come together in that workplace at one time. Okay. So I think one way that organizations can handle this is to brainstorm in smaller groups, in smaller sections, smaller departments, exactly where large groups can form, okay, and then take steps to reduce risks around the formation of these large groups in such a way that you ensure safety, you do not stop work, okay, and you can go ahead. So I think that's one message that I would like to leave you with. It's very, very important for us to think about effective measures. Okay, look at how COVID spreads and think about effective measures through which we can reduce the spread of COVID in the workplace. Okay, I keep saying in the workplace because we have no control over what happens outside the workspace, right? Some people commute, some people live elsewhere. We have no control over what goes on there. But this much we should be able to control. Okay. I'll maybe have more things to say later on when we go further in the discussion, but this is one major point that I want you to take away from the network view of the spread of epidemics.
Thank you very much, Shorindu. We have heard about some of the workplace measures and the importance of those workplace measures. We'll come back to it towards the end a little bit more, where Arnab will say a few things. But for the time being, let's go to some other aspect of the control, which is testing and tracing. Of course, as I said, if everybody can be tested for 2 rupees and 2 minutes, then all of us will get tested twice a day, and then we'll be able to contain this forever. But that's not the case. So I'll invite Ullas to talk about the tests that are available, to give us an introduction about what are the tests that are available, what do they tell us, and are there possibilities that we can implement some of those in a workplace environment, such as TIFA. Ullas, you are on.
Thanks, Sudipta. I guess much of the information that I'm going to probably tell you today is something that in bits and pieces, some of us or many of us have already been exposed to, probably the information exposure, but not the virus exposure. Nevertheless, I'm going to try and continue with where Sourendu left. The reason why we have to think about testing, and it's not just about looking at epidemiology, but also in trying to protect ourselves and everyone around us in terms of trying to either reduce the risk of infection or the burden of infection. I'm going to talk a little bit about that. The reason that becomes important is that we should consider whether organizations test their employees or workforce frequently, and by what method. Have the institutions done enough to identify vulnerable or high-risk individuals? This high risk could be either people who can come down with severe disease, or are exposed to infections much more than some other people. And what are the efforts that we need to take to mitigate super spreading events, which are very important. And these are the ones that actually often give you completely erratic spread of the disease. And that's where it becomes relevant. Now, when it comes to testing itself, there are multiple options that the virus itself gives us in our ability to test. One way to test the virus is by simply looking at the viral proteins, which I think Sudipta did allude to, which are basically proteins that are present on the surface of the virus, which is typically the S protein or the spike protein, or a domain within the S protein, which binds to the cellular surface receptor. So we could use these as one way to test. We could also test for the presence of the genome itself, which is the RNA, which again, most of us are familiar with, which is typically the molecular test that people do. Or you could check for presence of antibodies against any of these proteins. I will come to that later. Now, why is it important to even consider testing, right? And is there any merit? Now, this is not a prescription. These are probably points that not just SDIFR, but typically any organization should think about the pros and cons of thinking about doing this. Now, that's because of heterogeneity of workforce. I mean, if you had a homogeneous workforce, then the chances of spreading would be very different from workforce which is heterogeneous. So the heterogeneity could be stratified in multiple contexts, and of course you can bring in more correlates or features to this. One is, of course, the biggest component here is the travel. So you'll have people who travel and you'll have people who don't travel. Age and gender becomes important because we do now know that COVID has completely different etiologies or disease outcomes depending on the age, the gender of the individuals who get infected. Then a key feature is intermingling. At what rates, what frequencies, and in what numbers do people intermingle? And this is something that actually jumped out from our Sero survey and from several others. And even within slums, we see some pockets which are really burning red hot in terms of the number of cases, and some pockets are relatively less exposed, even though the slums are on an average are highly exposed. That really tells you that intermingling is important. Something that we did hypothesize is crowding, visits to common utilities or services are the ones that will probably increase the risk of getting infected. Then, of course, the risk factors. And here again, homogeneous or heterogeneous workplaces matter. We have all kinds of age stratifications here, so that becomes important. And I'll bring back the concept of super spreaders. The super spreaders are particularly worrying because super spreaders won't help us even if there is herd immunity, because you have this chance of creating a kind of a burst event where you infect a lot of people. So you have this ability to kind of perturb the homeostatic levels that you've maintained in terms of exposure, and therefore it makes sense to seriously consider whether or how frequently one should test, and what are the merits and demerits of those. Now, what do we test, right? And again, this is something that probably most of us are familiar with, but nevertheless, I will go through this. Now, the key is to capture people who are going through an active infection as of now. Now, that really depends on our ability to detect either the virus, which is the genome, which is the molecular test, or the antigen, which is present on the surface, and that can be done by various methods. Now, the critical thing is here is our ability to do a PCR is really constrained by, of course, the time that it takes, but also the cost. And you need slightly better trained technicians. That's a certain kind of setup to do it. Therefore, in fact, most countries are not testing as much because of the serious limitation. On the other hand, you do have this option of doing an antigen test, which is fairly simple. Most average technicians can do it. Very rapid, low cost, can give you answers within minutes or tens of minutes. These two have a immense potential to detect. But let's say if the PCR is not on the cards, we could think about, or organizations could think about, frequent rapid antigen tests. Now, there are caveats. We'll deal with those as we go along. But one other way of looking at exposure is the presence of antibodies. Of course, this works better if you want to look at a prevalence. I agree that this works only if you want to look at a community level exposure. Nevertheless, I'll tell you, for example, many organizations have started doing this, and you will be surprised to know that, of course, this is off the record information, that even Mantralaya, which is the Maharashtra government, has done such a test on all their employees, which is to know how many of those people have been infected. And they're interestingly looking at stratification of people who travel, don't travel. Now, then that will give you a kind of an estimate of what is the likelihood of us becoming infected in the near future. How risky is our population, or how exposed is our population? If a large number of us are not exposed, we need to take care of our measures much more stringently than otherwise. Of course, just because you have a high population which is exposed doesn't mean that we should take things lightly. It's just that it allows us to get one handle or one information on how to deal with the circumstances or situations. The second is, suppose if someone were to be negative from an antibody test, is it likely that then we go back and only in those populations do a rapid antigen test, which might give us a value of catching people who are either mildly symptomatic or asymptomatic, but still having an infection. Now, yes, in reality, the best test would be doing an RT-PCR, but at least it now narrows down the context or the window where your risk exposure kind of diminishes as we do things, right? This is just saying the same thing. When do you do these tests? Typically, you would do these tests very early on for your PCR and antigen tests. Your antibody tests are done over a period of time, and they give you positivity after typically 2 weeks. And as we see in from our study in the sero survey, these antibodies may not be lasting, depending on which antibody you look at. What's interesting is that the antibodies that are produced against this nucleocapsid protein, which is a protein which is sitting inside the virus, and therefore by default may not be giving much of a value in terms of ability to neutralize the virus, appears fast, but also wanes away very fast. Whereas antibodies that are produced against this spike protein, which is present on the surface, and in fact, it is this protein that the virus is using to invade our cells. This protein comes, the antibodies comes up a little late, but seems to stay substantially longer. And in fact, something that we are also doing in our study is to look at neutralization. So in fact, this antibodies are the one that provide you neutralization. So these are important considerations and whether we should do this. I'm not going to go into the technical details of the diagnostic test because I think there is enough literature. You can go back and Google it. But nevertheless, I would leave at this saying that diagnostically, we could use either PCR-based tests or antigen-based tests, and exposure levels can be tested by antibodies. This is a question that remains to be answered, and I think TF or any other organization should think about it. One of the things that come up is what about immunity and chance of reinfection? Although there have been incidences of reinfection, these have been far rarer, or the frequency is extremely low. And emerging literature indicates that probably the immunity is lasting longer than one would have dreaded otherwise. So looks like you're likely to be protected once exposed. So that's an important consideration, and therefore the merits of doing an antibody-based testing. The key feature that comes back is about super spreaders and identifying vulnerable populations, because it indicates that, again, your protective measures, and in fact, something that we did in our health care workers is that despite the healthcare workers being exposed to slum populations, where the incidence is close to 50%, the healthcare workers themselves were only 27% exposed, which means, if you're exposed to lower viral loads, if you are wearing masks and if you reduce crowding, the likelihood of you coming down with a severe disease seems to be low. Although there is less conclusive evidence, but I mean, all the evidence that points out is that if you do get infected, if you have lower viral loads, the severity of the disease seems to be lower. Your recovery chances are much better. So that's the way it works. So this is where I think we should think about bringing in our expertise to model numbers and look at testing and how we can possibly protect ourselves, but also give solutions to a larger community of what is the best way to stay protected. I'll end here, and if there are any questions, I'll take.
Yeah, thank you very much. Sorry.
Sudipta, just Ravi here, just a couple of quick questions.
Okay, Ravi, just 1 second, Ravi. Sorry, there are questions actually piled up. So I will go into a little bit of a question break, though we have a little bit of this, much of this left still. So if you can wait, Ravi, I will go over to Satya first, because a lot of people have said questions to Satya. I'll come back to you.
Okay, sure.
Only quick ones now, and long ones, please hold till the end. So Satya, over to you.
Okay, there are a couple of questions. So one, these are from YouTube, of course. One, maybe Ullas can quickly answer. Is COVID airborne?
Yeah, I mean, it's a difficult thing about, in fact, I've been reading about what is airborne, and it depends on whom you talk to. I mean, airborne diseases are, you can define it. I mean, in fact, people say that if you talk to an epidemiologist versus a virologist and a clinician, their definition of what airborne is different. I mean, one could take a very conservative view, saying that anything that spreads to air is airborne. But yes, maybe again, possibly Shankar and Arnab can also give a better answer. Depending on the humidity and the temperature, the range to which the droplets that carry the virus changes. And there again, you can think about what the definition of airborne is. Whether it travels through air ducts, again, I would probably leave it for Arnab and Shankar.
Yeah, Arnab will come and comment on that at the later session. This next
okay.
Session. But let's move on to another question.
Yeah, just one more question. So that was, of course, from Avinash Shinde. The question that's coming up is from Sanjeev Kumar Jha. This is for Sourendu. What about transferring this disease from materials, let us say chairs and tables of the lab, or sanitization of material are effective to what extent? So this is about, workspace, probably the question is. So Sourendu probably can answer.
I have a feeling that we'll discuss this later, but speaking, a quick answer would be that, yes, there is some risk of spreading through the surface, but we know very well how to take care of that. We basically use standard solvents, alcohol-based solvents, or soap and water, and we can clean surfaces. We can also clean our hands. Okay. We'll come back to this, I think, later.
Yeah.
Okay, that's it.
GRK.
Yeah, we go to Ravi now. Ravi, go ahead.
So, Ullas, the 10 lakh tests per day the government claims to do, which are these kind of tests?
Yeah, that's a good question, Ravi. Unfortunately, not every state entity that is doing this test is not revealing at what ratio they're doing the antigen test versus molecular test. So some municipal corporations like Mumbai, and I would believe Delhi, is also giving you granular detail about out of every 100 tests they perform, how many are rapid antigen tests and how many are molecular tests, but not every entity is giving you that information. So I think that is a difficult thing to answer. I don't have the answer.
Okay, and just one more. Of course, from Sudipta's initial remarks to all of you have said that testing is very important, and the government keeps saying. But the BMC did a test in our colony. Have you looked at how many people actually went for the test? There could be a sociological dimension to testing. Not everyone may want to be tested too. you can comment on it towards the end if all of you have ideas on this.
Yeah, so maybe we'll come back to it.
Discuss that at the end. Okay. Yeah. So then we come back to the main session, and I'll actually ask. So this question of testing and tracing, I'll quickly ask first Sandeep, Juneja, and then Shorindu if they have any comments on that, and then we'll move over to the last part. Sandeep, Juneja, do you have any comment on this testing and tracing things in a workplace that Ullas talked about?
Yeah, you can hear me. One thought we were thinking was what kind of testing strategy to have for TFR as a workplace. So one sense is that, it's good to, as Ullas also mentioned, to test for antibodies, sero-survey test, to get a sense of where we are, how many people are infected, what groups of people are getting infected more. And then if you do it over time, you get a sense of what the trajectory is. So that helps plan things better. So that's, that has its merit. I would suggest if you go in that direction, a reasonable sample size, because we discussed that sample sizes are important, because this is something which can be done in a random sort of way. You want to get a state of the workplace. So maybe around 500 people getting tested gives you numbers where you have a fair amount of confidence in the accuracy of the number. So I would suggest something like that. You do over a period of maybe a month or thereabouts to get a temperature of how the prevalence in the campus is growing. So that's very useful in deciding the policy. Now, in terms of tests like RATs, rapid antigen tests, their purpose is primarily just to find people who may be infected to prevent infection. So their purpose is to basically slow down the spread of infection in the community. So there, one should do it as much as one can, but budget is a constraint. So in that sense, one prioritizes on what people are likely to be infected, and if they are infected, who are more likely to infect others. So that becomes a criteria for selection. So people who are interfacing a lot with other people, they become the first group to try and test. Because if you can identify positives there, then you are slowing down the infection. So, for example, people who are working in the security or in the canteen, who engage a lot with others, people who are serving as well as people who go there often. That would be a criteria. Yeah. So that's all I really have to say on this. I just add one more thing, Sudipta, so in rapid antigen testing, that one kind of sees, are we really catching that many infections? And if we are, then we decide, okay, should we ramp it up further? If we are not, then we, adaptively we decide how we proceed further on this.
Sounds good. Shorindu, you have a comment on this? Unmute yourself. Shorindu, you are muted.
Yeah, sorry, I'll share my screen because I have a little thing to show there. Yeah, I'm just trying to, yeah. No, I can't seem to be able to share my screen. Is there something that you have to enable, one of you?
No, everybody's enabled right now. Is it possible to capture the essence if that's a problem?
Yeah, I guess I can without sharing screen.
And also,
Okay.
can you quickly share your slides to one of us?
Yes.
It's always safe.
No, it will take too long. I think I have just 1
say
minute.
it, I think. Sure.
Okay. So I think there are two parts to this question. One is about testing and one is about tracing. Okay. First of all, I think all organizations should have guidelines in place for contact tracing after the detection of an infection. Okay, to prevent widespread blow up of infections. TIFR does have this. Other organizations, if they want to open up, they should be doing this. The next question is whether regular testing is required. Okay, and the answer will depend upon what you want to do with the results. Okay. As Sandeep said earlier, there will be various reasons why you want to do the results. But supposing you want to use it to prevent widespread infection within the workspace, okay, how do you do this? And we know that exhaustive testing everybody is too expensive. So you can't do this very often. Okay, so you cannot, therefore this is useless. Okay, you have to do random sampling. It is more efficient. But once you think of doing random sampling, you have to have a strategy for the frequency of sampling. Okay, and Sandeep gave an example. So I will say from the network point of view, again, okay, you'll have to think about who comes into regular contacts with large number of people. So for example, the cosmetic maintenance in TIFR, people who go from room to room, they'll be in contact with a large number of people. They are at risk themselves, and they are also therefore able to spread it widely. So they should be more frequently tested than, let me take an example. Then, for example, a mathematician who works all by herself. So you could have a policy where the frequency of testing will have to do with how many contacts a person will have per day inside the workplace. Or you could add in other weights like length of the commute, because somebody who's commuting for a long time could be more infective, okay, plus the number of contacts. Or you could also weight it a little bit by other things like whether or not he's a member of a more susceptible population. But eventually there's an organizational decision about what to do if somebody tests positive. Do you request them to quarantine themselves? Do you require them to quarantine themselves? These are important questions that one has to think about before starting on testing. Thanks.
Okay.
Thank you very much, Shorindu. And that's something to think about. Jyotishman, you were saying something?
Sudipta, there are a couple of questions in the chat that you should take. It's relevant right now.
Okay, so you go ahead.
Okay, so Alok Ray, our TFR member, he's asking to Shorindu, if virus remains airborne for some time, Shorindu, how will staggering students or workers occupation of a room be optimized to minimize risk?
We will talk. I think Arnab will touch upon that point, and maybe then Shorindu can also join in. But let's just leave it for.
Okay, and again, the same kind of echo question has been echoed. Should we stop central AC of the institute to minimize?
We are coming to that right next.
Yeah.
Right.
Okay.
Okay. All right. So yeah, thank you, Shorindu and Sandeep and Ullas, and we now move over to other workplace measures. Okay, we are testing and tracing is something. But other workplace measures where we'll talk about best practices, and we'll discuss about things to do in the office, in the canteen, and then also we'll talk about measures that may help precisely these kinds of questions, what to do with central air conditioning, ventilation. We'll even touch upon about things about a thing or two about masks. And if I get time at the end, I'd like to say a few things about working outside, because TIFR has such a nice environment. Lot of workspace, especially now the monsoon is over, we can do that. So we'll come to that one by one, but the main actor here is Arnab, main speaker. Arnab, over to you.
Hi, I hope I am audible. Yes?
You are.
Yes.
Okay, so as Shorindu said, it is workspace networks that are key, but I also think it is how we arrange our workspace that has a very critical role in, dealing with continuing our existence, continuing our normal activities in the institute during a time where this pandemic is still around. And one can, of course, think of many possible solutions. And remember that it is not possible to isolate ourselves completely. I mean, we cannot live in bubbles, right? And hence, of course, let me also get one of the earlier questions. Is COVID airborne? If you want a short answer, the answer is yes. One has to assume, yes, it is airborne, and that is the main mode of transmission. It is much more likely that the virus spreads through droplets and things in the air rather than through touching something on a surface. So transmission from surfaces And even if you don't do anything to a surface, the virus doesn't live there forever. It's going to go down very quickly on most surfaces, right? So even if you did, in fact, I think if there is a case in the lab, I think for most of our labs, we should not get paranoid and start spraying stuff around. Just if you close the lab for 48 hours, 72 hours, whatever, you can decide depending on the level, that's good enough. I mean, time is what really will take care of things. Also, there are measures that one can take. One can always think of very high-tech solutions to come up to cope with a problem. But there is also an issue of what is practical, what is doable in a short time span, and given that we have, especially now, close to zero budget, or very limited budget. And one of the things which personally I feel is really important is to worry about ventilation. If it's something airborne, the first thing you want to know is how much air is passing through here. If there is somebody in the room who is potentially a shedder, who is shedding viruses, how long will that thing take to go down? And people talk about things like how many times an hour is the air getting replaced in a building, etc. All those things, calculations, you can work on that. But remember that we have a institute where things are as they are. Many of our designs for air conditioning and ventilation, etc., are legacy designs which we cannot change overnight. Our rooms have, for example, fan coil units, which are effectively cold water passed on a grill, and just a blower over there. It's not really injecting any fresh air in the room. So fresh air comes when you open the door through diffusion below the grills, whatever. There are some ways in which fresh air is coming in. So we have to be careful. And as Sudipta has already alluded to, and I'm not going to show any slides, I'll maybe show one picture, but want to keep more time for discussion. See, Mumbai, the worst months of Mumbai are over, the monsoon. And the muggy month of May before the monsoon, April, May. The only 6 months in which Mumbai is reasonably okay to be outside are starting now when we want to open up. And we actually must, the easiest thing we can do is to try and use the open spaces we have. We have a Shamiana, for example, behind the auditorium, but similarly, we could use our terrace spaces. I mean, after all, we're not moving labs on the terrace, but at least we can, eat outside. We can meet outside. So if we use our open spaces a little bit more creatively, and just as an example, we don't even have, like, for FOS, when we used to organize these outreach events in the lawn, we used to put up umbrellas outside in the lawn. And of course, we had schools congregating there. But if we put up umbrellas and we have 2-3 people under an umbrella, that's perfectly fine. We could, just go ahead and put these out. So, if we just use our outdoors and spread it out, because even the slightest breeze outside is going to ventilate the area, move particles away much faster than what is going to happen inside a closed office, right? And for most of our offices, if there is someone else in the office, I would very, very, very strongly recommend that we continue to wear a mask at all times. At all times, if I know that, yes, there is absolutely nobody in the office, I will remove my mask like now because I'm speaking, but otherwise I wear a mask at all times. And the other thing I would want to say is that a poorly worn mask is a very, very false sense of security. If the mask does not cover your nose, right, there is really no point in wearing the mask. So chin ornaments are completely useless. And I see a lot of people, even now, even in spite of the posters being put everywhere, not wearing masks properly. And for a place like TIFR, I think that is something which we must teach ourselves, that, regardless of the comfort level, if we are going to be outside in public spaces, we are going to wear a mask, whether it looks bad, feels bad, whatever. Otherwise, stay at home. But if you're coming in the public space, you have to wear a mask. I think there is just no, we have to be a little strict on this. This is what will allow us, and masks work. There is no dearth of examples right now where masks work. And I have already gone a minute beyond the time I was supposed to speak. So I will stop here, and maybe as questions come, I can help take some of them.
Thank you very much, Arnab. And you stopped at the question of mask. I'll request Shankar to make a couple of comments about mask for a couple of minutes. We are already 15 minutes over time, so we need to bring this to a close.
That's okay.
Yeah, Shankar, go ahead.
Yeah, I don't have much to add except that you see the question of airborne or non-airborne depends upon where you are. So the whole issue is about if you are outside and there is a lot of air in the system, ventilation in the system, then you are basically well enough with a poorer quality of a mask. If you are inside, then you need a better quality mask. And the question about airborne things actually becomes more important if you're inside a place and if you have many people sitting up there, because that's where you are breathing out smaller droplets, and those droplets tend to be in the air. The second of all is mostly our ACs are so designed that it is to take care of your body comfort. However, if you have droplets and if you want to get the evaporation rates of the droplets, then you'll need to set the humidity levels also at the right position, and it needs to be worked out. Okay. A third thing would be, it's a good idea that if many of these air blowers that we have do not have enough wind in the system. So if you can actually have slightly windy rooms, that means have a fan close by to you, and if you start on the fan, even then what you'll do is you'll disperse these particles off. You disperse these particles, you take these particles to the wall, and they stick onto the wall, and you might be slightly better off. And these are some jugaad solutions that, at this situations, because you can't do anything much better than that, that might just work for you. Thank you. That's what I wanted to say.
Thank you very much, Shankar. And what I'll do now is that we have pretty much covered all the things that we wanted to cover. I'll quickly run through the speakers once if they have one snippet of something that they wanted to mention. So I'll start back with Sandeep Juneja. Sandip.
No, at this stage, I guess nothing major comes to mind. I think just reiterating Ullas's point earlier that what's good about wearing masks also is that even if you do get infected, typically research suggests that you don't get infected very severely. So that's another reason to keep in mind that, we are in for a long haul right now. If you ask yourself, what's the end game? Vaccines look far away. The only thing we can do is kind of flatten the curve, keep ourselves protected, slow down the spread of the disease, and or reduce the severity of it. So, and that's so masks and all are play a great role there. But beyond that, I don't have anything further to say right now.
Thank you. Shorindu, you want to say something? You are muted.
Unmute, Shorindu, unmute. That's okay.
Yeah, thanks. I'll just say a few things about workplace safety very quickly. And I want to approach it as a scientist. And since I'm talking to a lot of scientists, I want to talk a little bit about open scientific questions here. Okay. Because TIFR can actually study some of the basic science here. Okay, there are a lot of models, but very little data. And we have the ability to produce the data and to interpret and to model it. Okay, so just some quick numbers. As far as I'm concerned, from the literature, I see that the virus spreads mainly through the air as aerosol droplets. I could take the radius of those droplets to be between 1 and 100 micrometers. Okay, that's because masks will probably filter out smaller particles. Smaller particles are not important for another reason I'll come to. Okay, so if I take the radius to be between 1 and 100 micrometers, then the masses of these droplets are of the order of 10 to the 11 to 10 to the 17 daltons. Okay, they're not very large. And their weight is like 10 to the minus 2 to 10 to the 3 piconewtons. So little forces can allow them to stay in the air for a long time. In comparison, the mass of the SARS-CoV-2 virion is about 10 to the 7 daltons. Okay, so you see, even if you have much smaller droplets cannot carry too many of these virions. If you have an N95 mask, which basically cuts out everything above 0.3, then you're releasing very few virions into the air. Okay, Surface cleaning is not a problem. Okay, it's technically simple. As I said before, use standard cleaning solutions, so we don't go into this. Okay, but cleaning of volumes is a technically challenging, and technically both from the engineering point of view and from the scientific point of view. The two control parameters here, what is the humidity and what is the temperature? Okay, and what we want to do is within this phase space of control parameters, we want the contours which ensure the most efficient evaporation of droplets. Are there simple estimators for emitted viral load and safe dosage, which our biologists can tell us? Okay, so that physicists can take over from there and look at this evaporation problem. Okay, what is the rate of viral loading of air under constant infection levels, for example? Can we get this? And then we have to worry about how to remove this. Okay. Another thing that sounds interesting, and this is a discussion I had with Shankar in the morning, is that aerosol characteristics could depend on the sounds produced. Okay, because your throat vibrates in different ways. So you expel different amounts of air, different amounts of fluid. Does this actually then depend on the language that we speak? Because different languages use the throat differently. Okay, we make different sounds. Okay, it's a question that we could answer empirically here. How well does masking while speaking reduce the viral emission? We could actually measure that. Okay, should we use HEPA filters or UV treatment? We could actually answer that question, which is more efficient for what kind of droplet size. So there are lots and lots of open questions here, all physicsy questions, okay, and a lot of biology input. It's a wonderful opportunity for a cross-TIFR thinking, cross-TIFR science. I think I just wanted to say that. Thanks.
Thank you. Ullas, you want to say something?
It's just that I think given that, as Sandeep said, vaccine is far away, the one thing that we should consider, any work, we are not a very large workplace, at the same time we are not a very small workspace. The risk is if you have a major burst in one section of TIFR, what would be implications be, how long will be shut, and how that might impact all of our works. So I think given these, the pros and cons of contact tracing and testing should be employed.
Okay. Thank you. Okay, so we go to quickly to Arnab and then to Shankar if they want to say. So Arnab, here is your 1 more minute.
Okay, so I've just been looking at a few of the questions which are coming up about especially putting filters. Now, it is near impossible to suddenly put HEPA filters on all our AC ducts and things like this, simply because you put a filter, you add a pressure drop. And if you want to get the same kind of flow rates that you need a much bigger blower at the end of it. So this is what I meant by, we can't overnight change our AC systems. So we have to, and we can't shut off the AC system either. I mean, most of our labs and rooms are designed that, without light, for example, or AC, we will not be able to use those indoor spaces. So I think we just have to figure out simpler solutions for these things as far as possible.
Thank you. Shankar, anything you want to add?
I think even 6-7 months down the pandemic, it's still, if you look at raw data, regarding aerosols, droplet distributions, how things move, especially at the relevant zones. You have a lot of high-speed videoscopy, but mainly they are more beautiful, else than useful. So essentially, the data, the hardcore data is missing. Even at the scale of TIFR, there's enough scope for us to extract data, because you can't model things if you don't have data. Droplet evaporation rates, you can have so many papers that are being written about on modeling about evaporation, how droplets dry, and all of these things, but very little about real hardcore measurements. I think this is good time that measurements have to be done, and it cannot be just simulation driven world.
Thank you very much. And I think I'll just have my 1 minute sentence, 1 minute time here. And I will draw upon something that Shorindu mentioned, something that Shankar just mentioned, and probably all of us have in mind. It has been wonderful last 7 months working together, colleagues from different parts of the institute, including different centers of the institute. Not only the expertise and the dedication, but also the passion and the courage is really wonderful. Even today, I got a mail early in the morning from Kullaneshwar Mandal that Eureka, he has a mini protein that binds very strongly. Do I want something to do with it? So this has been unprecedented. Many of us has dropped exactly what we are doing, or at least set it aside and jumped right into it. What we missed was to have a very proper virologist, okay? A virologist, a couple of biologists who worry about these things, clinicians. So this is, I think, a chance for all of us and the TIFR administration to think about that this virus is here to stay. And if this virus, if you look at the past 20 years, these viruses, the SARS-CoV-1, the MERS virus, the Ebola keep coming in. And here something has kindled the interest of a lot of different people, from statisticians to theoreticians to biologists. Can we not herd these together and have some kind of a virtual center somewhere? Actually, let's go ahead with it, because we have already intellectually and passion-wise invested so much into it. I would be really, really happy if some such seed happens somewhere and we join hands, at least part of our time working towards it, because a lot of us have given a lot of time to that. So that's kind of an appeal for all of us at TIFR to think about and to think creatively about how this can contribute ultimately to the nation. We should lead, and we can lead. We need to think clearly about it. So I'll stop here and I give it over to Jatishman to handle all the questions.
Sure. Thank you, Shrutada. And I would like to now tell my co-host Satya, who is also along with me hosting this session, to sort of open up the question space for all of us. So I will sort of take few questions from here first, Satya, just because Lokeshda had been trying to ask a few questions. He'll be raising his hand. Lokeshda, please. Oh, your audio is not coming. So I will just read your question, Lokeshda, which you have posted, which is to Shorindu or anybody in the panel. 2 people at 1 meter distance with wearing masks, is that considered as contact at a workplace?
I'm probably not the best person to answer this. I think Shankar or Arnab will be better. So instead of guessing, I'll ask them to answer, if they can.
Again, my take would be, for how long? I mean, and what are you doing? If you pass each other at 1 meter distance, wearing masks, I don't think that's contact at all. If you stay there for 5 minutes and just have a very brief chat, I don't think that's really something to worry about. On the other hand, if you stood next, facing each other and yelled at each other for an hour, that might be a very different thing, because yelling versus speaking, for example, people have shown that it has a huge difference in the amount of particles one throws out. So it just depends on what you did at 1 meter distance away. But
let's all learn to speak softly.
Yeah, so in most cases, if you wore a mask and you're 1 meter away, fine if it's a short interaction.
Sudipta, I would say let's not air our views very strongly.
Yeah. Okay. Okay. I will take another question from a student, Devanjana. Devanjana, could you use your mic to ask this question on testing?
Yes. So my question was, if time or budget is the issue in testing individuals, how effective is the concept of pool testing? Or can this be used for groups or colonies in which a large number of people are to be tested? Thank you.
Can I answer that? Because I thought a little bit about it. Yes, Devanjana, this is a very good point. And in fact, one of our ex-colleagues, Manoj Gopalakrishnan, has come up with some strategy for pool testing. It has been tested, actually. That strategy has been actually field tested in NCBS, and it works wonderfully well as long as your level of infections, that is, what is the positivity probability in a sample, is less than, let's say, 5%. And I do believe that if we do that in TIFR, that will be less than 5% on any given day. So I think there's a wonderful idea, and this can reduce the number of tests required by a factor of 10 or so. So yes, but it's still, of course, something that is still has to be organized. It's still quite costly, etc. But yes, we can do that with a factor of 10.
Satya, could you go ahead with your YouTube?
Yeah. So I think there are a few questions which might be also repeat, kind of partially answered or whatever, but let me nevertheless go one or the other. So this is Kausalya Srinivas. What's the contact tracing protocol for TIFR mechanism? I mean, in mechanism. So,
yeah.
Okay.
Okay, so I will let Shrirup is here today. I'll go beyond the panel. Sudipta, if you can please excuse me, because Shrirup could
the best possible answer.
Yes.
Yeah. So okay, thanks. It has already been circulated. The contact tracing, if there is a person who is found to have the COVID virus, who tests positive, then the corresponding lab PI or the section head or whoever is the head of the office is given the responsibility, because that person will know essentially who that person is likely to be in contact with. There is a questionnaire which has been circulated to everyone, and those questions, which are basically quite comprehensive, they're also taken, created by our medical officer with consultation with BRC and I think TNH. So those questions have to be answered, and once the persons who are there, that there is a small committee, which is the risk assessment committee, which is consists of the deputy registrar, the security officer, and our medical officer, and they would advise on who are the contacts who are supposed to go into isolation or not. So we have this procedure in place, and the detailed questionnaire and so on have all been circulated.
Thank you, Shrirup. Yes. Thank you.
Okay.
Satya?
Jaideep, Jyotishman, I think there are a number of questions. Maybe I request the panelists to, because a lot of things have been said, they can be a little brief in answering.
Please ask the question.
Okay. So if airborne is meeting outside or eating outside or working outside safe?
Yes.
Okay. So that's the answer. A very basic question, given the institute is largely centrally air conditioned, does it make more sense to keep our office doors open or closed while inside?
Somebody answer, please.
Yeah, I think that if you can keep your office doors open, it's better.
It's better. Okay.
That's what I would suggest.
Okay. So that was Ram Prasad, and this is R. Vijayaraghavan. Why isn't there a significant effort to make a cheaper, more comfortable mask, which people might be willing to wear and for longer?
Yeah.
Well, I think it's called a cloth mask. A cloth mask is cheap, it is comfortable, and you can wear it for a long time. And actually, the amount of reduction you get on wearing a cloth mask is probably good enough in most cases, in most office cases, whatever we are dealing with. Unless you are in a situation where there are 10 people in the room and you're crowded, or you are dealing with, like in the medical section, you're dealing with people who may be are possible people who may have a infection or something. There is really no need for the general public to be wearing N95 masks. N95 masks are not comfortable for use for 8 hours a day because they have to seal completely against your face. And if you're wearing an N95 mask which doesn't seal against your face, you are leaking air from outside, which is unfiltered air. So that is probably defeats the whole purpose of wearing a super duper mask. You're better off with a cloth mask, which is comfortable and you can use all day long.
How many layers of mask?
Cloth layers. At least 3 layers.
Okay. Okay.
There was a question again about the something what is called a sanitizer tunnel at an entry of every block, or is there a proposal?
I will say that those things are complete garbage. I'm putting myself on publicly on record over here, but it is virtually impossible that, see, clearly you don't want to spray people with bleach or something, right? Most of these sanitizers, something, there is no way that you can, if you're walking through a 5-meter distance, that you're going to get these spray particles reaching every point, and you are unlike, and anyway, you're not really worried about what is called fomite transmission from surfaces. What you're worried about is airborne transmission. So yes, that 5-meter tunnel is fine. After you walk out of that, what happens? So that all these things about sanitization tunnels and all are hype, which are not useful at all.
Okay. Why is
maybe I could add something. Okay, I think at one point, very early in the pandemic, people were worried about what is the main mode of transport. Okay, at that time, people worried about whether it can get onto your clothes. When you go out and you come back again, should you wash your clothes instantly or not? Okay, now we know that this is not a big problem. Okay, it's partly understandable from simple physics. Okay, the speed that you move at is not high enough to create extremely turbulent flow in the air around you. So what that means is, even if there are virions around you, you walk through it in a streamline, more or less in a streamline, and it never comes and deposits on your clothes. Okay, we don't need to worry about such things. So we don't need to worry about this kind of tunnel and so on.
Okay. The next question is why there isn't a RAT done institute-wide? Of course, it is done.
That means
rapid action antigen test. Is there
okay, just some numbers. I think rapid antigen test kit costs between 500 rupees and 1,000 rupees. So let's say 1,000 rupees. Okay, there are what, about 1,000 people in the institute? Okay.
Yes.
So that's 10
it's
to
much
the 6
less than that, Sourendu.
Yeah,
yeah.
But yeah.
So that's 10 to the 6 rupees for every time you want to do a test. Okay, how many times will you be able to do it? It's much more important to keep track of what's happening more or less on a weekly basis, rather than saying, okay, last month we tested everybody and it was all okay.
Rapid antigen.
Okay.
Okay. Is transmission of virus depend on temperature of surface of the material?
I don't know about the transmission, but the lifetime of the virus on a surface is clearly dependent on this temperature. So, if you're at very cold temperatures of 10 or 15 degrees centigrade, people have shown that it actually can last longer. But once you're above 40, 50 or so, the lifetime is very short. And if you're at 60, 70, it's a matter of a few minutes perhaps. So yes, that way it matters, but that's okay. Which is why heat is such a good way of heat is a good way of cleaning out things or disinfecting things.
I'll just mention something that initially it was there were some reports saying that on such and such surfaces, say on a cardboard or on steel, it lives for 2 days, 3 days. But much of that report actually has been proven to be wrong, in the sense you do find virus parts, but it is very difficult to have live viruses on that for so long. So it is now pretty much known that if you take common precautions, that surfaces would by far not be the main way that you'd get infected, because viruses don't live for very long on the surfaces in a way that they can reproduce themselves.
Okay.
Okay. So Jyothishman, you can go ahead. Yes. Yeah, please.
Yes. So there are a couple of show of hands here. G. Ravindra Kumar, who is our next colloquium coordinator as well, he has few questions, and then we have a question from Diksha. Yeah.
So shall I go ahead, Jyothishman?
Go ahead, GRK.
There's been an interesting study in Science this week about 2 states, Andhra and Tamil Nadu, and how this by this Lakshmi Narayanan from the US and India, the concept of super spreader. What makes someone a super spreader? That's number one. And the second thing is
can I answer that quickly before you go on? Yeah. I don't think it has much to do with the individual. Anybody could become a super spreader. It depends on the circumstances.
Okay. It's not by somebody by disposition is likely to be more
unlikely. Yeah.
That's unlikely. And the second thing is that, of course, we should calm people, saying that, as you already said, that you need a minimum time of interaction. Just passing by doesn't give you, because most people are still very scared of that. I think it hasn't gone out. And you need a minimum concentration of the virus that you have to absorb before you see effects of that. I'm not saying that people should let their guard down, but I think they should not panic either. And I'm going back to my first question about if testing is so important, it is not that people will want to get tested. You know, you are saying that unless you mandate testing by something, that will make it impossible for them to avoid. Because in the colony, the results have been, I think, fairly the other way. Very few people got tested in TIR, even though it was free.
Okay. Could the panelists
Anybody can
answer?
comment on that?
Yeah, panelists answer that. Maybe Ullas. I would like Ullas to have a comment on this. Ullas?
Yeah. So basically, I think. I mean, there were two questions. Which one do you want me to answer about? One is the spreader and the
I want to know why in a community like TIFR, the testing rate was so low, even though it was free. It's an honest appraisal we should do here before we mandate testing, you know, for everyone across the country.
So the thing is this: it's an interesting sociological question, and I guess there are two reasons for this, and at least this is based on what we also found in particularly the high-rise communities. So one of this could, I mean, TFR can probably be an admixture of both, very complex, behavior where probably people are worried that what if I get tested, will I be put in the quarantine, taken away by BMC? That's one, fear. The other one is, how do I care as long as I am protected? Now, this is an interesting thing that we found in the slightly affluent neighborhoods in Mumbai, and I think we being we and us being us, based on whatever also scientific knowledge we have, we may disregard the importance of this because we not see a value at an individual level, although there might be a value at a community level. So it's how you value about what it means to you versus the community. It's likely that because we may not value subconsciously, that we say that, okay, what is it in it for me to know whether I was already exposed or not? We may not value the impact that it will have at a community level. So it is at three levels. One is the fear. The second one is, as long as I'm protected, how does it matter? I mean, these are all very intrinsic behaviors. We may not voice it, but it's probably there. The third thing is, what does it mean to me? I mean, even if I'm positive, who the hell cares? If it doesn't matter what the community wants. As an institution, there are people who want to deal with this, and they'll deal with it. I will take care of myself. Okay. A typical stereotypic behavior.
Maybe I could also add something.
Yes.
I think if you want to have mandated testing or random sampling to check people's health, the institute will first have to decide administratively why you want testing, okay, and what happens if you are asked to be tested and you don't do it, okay. These are important administrative issues which have to be dealt with before you institute a testing regime. I think we can't just think of it scientifically, because there are clearly many more issues involved. Okay, yeah. As a scientist, I may want data, but that's not how everybody looks at it. Okay, we have to think this through as an institution.
Okay. Okay, I'll quickly take a question from Diksha and then Sanjay Vategaonkar, who is also switched on his video. So Diksha, your question was, what determines the chances of a reinfection? Maybe Ullas or...
Yeah, that's a good question. So there are two possibilities, either because the immunity wanes away, which is possible. That means the immune memory is short-lived. Doesn't seem to be the case. The second possibility is that you are infected with a mutant version of the virus, and therefore maybe the system is not able to recognize it, and you've gotten a reinfection. At least in the Indian context and elsewhere, I think the reinfections have been largely based on a mutant virus. So it's quite possible that it is a combination of both a short-lived immune response and also a mutant.
Okay. Ullas, this is just a connection to your response. There is a question I'll just take before Sanjay. Meghan Patankar is asking, any comments on different strains and mutations of the virus and its strength in creating symptomatic versus asymptomatic infection?
That's a good question. I've not kept a track of that part of the literature, but we do know that there are multiple initial isolates that came in, and there is likelihood that these have undergone changes or mutations as they've spread in the population.
Okay.
A careful evaluation of severity also depends on the cohort that you're looking at, because often the severity is dependent on the immune response, which we know is based on both gender, age, and the comorbidity. So it's not easy to just correlate viral strains or variants with severity. It has to be in conjuncture with the host response.
Sure, Ullas. Thank you. Sanjay, you can please ask your question, unmute yourself.
This maybe Ullas or Sudipta can answer this. We talked about this thing being airborne, and that was related to the evaporation rate. So my question is, if the particle becomes completely dry, would that protein get denatured and the virus would be ineffective?
Yeah. Okay. Yeah, I think.
Ullas, you go ahead.
Ullas, you want to answer?
Yeah, denaturation. I mean, I don't think people have really looked at denaturation because it's difficult to really capture that on in the droplets or aerosols to see whether how much of denaturation is there. It's quite possible there is denaturation, but in aerosol capsules, possibly the virus is still protected. I mean, you will have some infectious material. So it really depends on what extremes you're thinking about and whether the conditions are good enough to expose. But to denature, of course, you need to take it to very high temperature. So Sanjay, that's a bit tricky to answer. So unlikely, I mean, unless you really go, at 37, 38, 40 degrees, I don't think these proteins will denature that easily. Of course, there will be an effect, and therefore one does see that even on surfaces, the half-life of the virus is constantly decreasing at some rate.
Okay. The reason I asked you was see, in the AC environment, if it becomes dry, would it, and that relates to the level of humidity and the temperature. So if you have a nice dry atmosphere and the aerosols get dry quickly, then that virus would be effective at all, or then we don't have to worry about being airborne or not in the AC environment.
Maybe Arnab or Shankar can.
Yeah, Shankar probably.
So the point is, if you have a dry environment and say you have a droplet, then you will tend to evaporate very fast. So typically droplets which are less than a micron tend to evaporate very fast, even though they can be airborne. So now if you have got an airborne viral just piece and it goes and hits a surface because you have convective flows, every time it hits a surface, it gets absorbed to the surface because of van der Waals forces. It just sticks to the surface. So that's the whole idea, that it's a good idea to get something dry, because if you're dry, then you don't, this coated viral particle doesn't exist. If you get your humidity high, typically in Mumbai, when you get the humidity up to 80 to 90% relative humidity, the lifetime of small size particles can be really very, very long, very long. So you imagine in that such a situation, if your humidity is about 80, 70, 80, 90 in a room, and all of you are speaking, and and none of these droplets are actually evaporating out and they're just hanging around in the air, after some time the dosage will start to increase.
Okay.
So this is
Sanjay, can I chip in to ask to say something?
Yes.
Okay.
Muted.
Sanjay, you're muted right now.
Sanjay, you are muted right now.
Oh, sorry. So the thing is that
may I, before Sanjay continues, may I say something here?
Sure, Shorindu. Yes.
Yeah. So I was looking at WHO's guidelines for air conditioning and ventilation, and it says something which makes me think that perhaps we don't know everything about the virus. It says that you should set the temperature between 23.8 Celsius and 26.9 Celsius. Okay, very narrow range. And you should set the relative humidity between 50% and 60%. And it says colder and drier or warmer and wetter are worse. Okay, so that makes a connection with the question that you asked. Okay, is the hydration of the
Dehydration.
lipid layer somehow important for the thing? It must be. But if there's a small range where the AC is most effective, then it's not clear why that is happening.
See, I would like to extend this discussion to the whether it's safe to be in a close air circulation as TIFRs, because if I can just take the thing from Shankar, whenever it hits the walls and any obstacle in the path, it is going to stick to the surfaces. So by the time the air gets recirculated, it going through so many filters, so many ducts, it's very little chance that it will transmit and go, and we don't probably need to think about anything like HEPA filters or those kind of things. Because if it just goes through the filters and multiple ducts which are bent at 90 degrees, God knows how many times. So I think we really don't need to worry about that aspect. That's what my
Sanjay, it's not true because, sorry, this ducts is actually what Sourendu referred to. This is a lamellar flow. See, unless you can move through it through a mesh, you know what will happen is the ducts, the particles will tend to avoid it. What I meant was a normal impact that you have to receive it on a normally. Otherwise, if you have a bend, then because there's a lamellar flow, you just will pass through it. It will just glide through it. It's only by inertia and by Brownian nature that the particles tend to get stuck to the walls.
Okay. Shorindu, you want to add something?
No, I think airflow, what was said is absolutely correct.
Okay, fine. So we will actually sort of like to conclude at this point. And there have been some interactions going on, and Sandhya has been also answering some of these questions. So Sandhya, thank you for those answers. Also, I would like to ask Satya, do you have any pressing questions that you would like to take now?
Just a second. I don't think so. Okay.
Okay.
Yeah, there's one second. Ramprasad Saptarshi, again, building on Ravi's GRK's question, that is, what should we have done in hindsight before our RAT in the colony so that more people may have come forward for voluntary testing? So
this is, yeah, I guess Shorindu alluded to some of it. So yeah. So okay. So Satya, do you want to then?
Yeah, nothing more.
Conclude the session then. We will. Yeah.
No, you please go ahead.
Okay. Well, I think I would like to conclude this first discussion room on COVID pandemic officially close. We are very thankful to all the panelists today and the moderator, Sudipta, who had thought about how to, diagrammatically put this thing together. So thank you, Sudipta, for the entire effort, as well as to all the panelists, colloquium speakers, essentially, from the last 1 month. I would like to thank Shorindu, Sandeep, Shankar, Arnab, and Ullas, of course, for doing this for this community, but not only for TIFR, but for everybody at large, and getting together and discussing this very important problem. But I would like to state one thing at the end. We have had a tremendous discussion about the scientific merits and demerits about multiple things. But at the end, as a community and as an individual, there's a lot of responsibility that rests on us of our behavior during these times. And I hope that this particular discussion will enable you to make informed decisions and how to act in a crowd and inside closed air spaces. So with that, I would like to conclude, and I would like to say that if Satya wants to add few more comments.
Yeah, just one point. I think this is Sudipta's point. I hope I understood that well to be able to respond back. And Sudipta was our first chair of Technology Transfer and Resource Generation Committee. Yes. I'm not sure if that was what was kind of computing when he said this. In a way, COVID has brought lots of unprecedented situations, economy, behaviors, and laws, and whatever. But also, COVID has drastic changes in terms of the way we use technology, one that are actually using. In fact, so much so, people say necessity of is mother of invention. I very jocularly used to change this to say necessity and frustration are parents of invention. But that's of course on a lighter vein. But I think Sudipta was actually saying that time has come in some way for a bigger retrospection to TIFR to kind of little bit channelize that few percent scientific ventures that should also have a clear mandate in order to do something that will help society on a shorter scale rather than 110 years after a scientific principle was discovered, which anyway was happening all along. So I think this, you can say Ullas, you can say Sandip, I mean, everyone of Arnab. I think this, also he mentioned about something came from centers. So this is very important. I hope we will kind of keep in mind when we really talk about long-term plans of institute and how we have to little bit reorient ourselves into becoming more visible, more relevant, and more useful to the community that we live in.
Okay.
I agree with you, sir.
Completely agree.
100%.
Thank you. Thank you, Satya. And I would like a brief round of applause for everyone associated with this discussion. So Satya and Dal, please join because this was fascinating. And I would like to remind that we're going to return next week with the Shanti Swarup Bhatnagar awardee Rajesh Ganpati joining us for his talk next week at 4 o'clock. And also I promise that this is not the last discussion room on COVID. There'll be a new panel, there'll be a new set of colloquium speakers and a moderator then from 6 months from now, and we might have a completely different discussion at that point. So thank you all for joining today.
Thanks a lot, Jyotishman. Thanks a lot for thinking about the whole thing. Thank you.
Thanks, Jyoti.
Thanks, Satya.